Okay, so I think it's recording.
It's 8:30.
Hello, everybody. I want to welcome you to the 2019 ASSFN seminar series on epilepsy and epilepsy surgery. Today we have 3 talks. The first talk will be by Dr. Mike Sather at the Penn State Health. He's the Associate Professor of Neurosurgery and Surgical Director of Epilepsy. And I'll let him begin with his talk. That will be followed by Dr. Jorge Gonzalex-Martinez at the Cleveland Clinic, who will be talking about laser ablation, followed by a talk on anterior nucleus DBS for epilepsy. I just want to remind you that this seminar is being recorded for your convenience, and if we can hold off on questions until the last 15 minutes, that'd be great. So I'll let Mike take it away from here.
All right, thank you. Hello, everybody. I'm going to talk to you today about ROSA, which stands for Robotics Stereotactic Assistant. This slide is a good backdrop here with Star Wars as we get to talking into robots. But ROSA is very much real and not science fiction. I'm going to move along to the next slide here if I can. Oh, there we go. All right. Sorry, it's a little bit touchy, the mouse. Okay, so for an outline today, we're going to talk about the history of robotic surgery, discuss the goals of robotic use in surgery, the differences between general surgery use of robotics and then neurosurgery. We have differing goals. Talk about the stereotactic options currently available to us functional neurosurgeons, introduce what ROSA is, discuss a workflow for its use, and discuss some potential neurosurgical cases and show a few, and then discuss how robots can help you build your practice. So 1980 saw the birth of robotic surgery, and in addition to several feature films, science fiction, robots. But again, sorry, the mouse is very... So robotic surgery as a field is only about 30 years old, which is relatively young, of course, in medicine. There's been an exponential growth over the last 10 years. And this has coincided really with the rapid expansive technology that we've seen in the marketplace. And it's also paralleled with the minimally invasive surgery movement that we've seen in the last decade. The first robot was actually used in British Columbia in 1983. And it was a robot used for hip arthroplasty. It had an unguided articulating arm. And this is what that Arthrobot looked like, again, 1983. So pretty old technology and pretty primitive. It may be surprising, as it was to me, for many of you, that the first case of robotic neurosurgery was actually performed in 1985, and it was a brain biopsy, and this was the device utilized called the Puma 560. So the growth of robotics in surgery really came from military funding, because as the Stanford Research Institute was creating this prototype surgical robot, which eventually became the Da Vinci robot, it was sort of picked up by the military, and DARPA ended up funding quite a bit of the project. And the military was interested in lowering wartime mortality by allowing surgeons to operate remotely on wounded soldiers. So they didn't really have to be present on the battlefield, but they were able to take care of the patients was the thought. And this concept is called telepresence. It's where you can utilize a technology to operate on an individual via telerobotics when you're not at the same location. Da Vinci robot really allows for telepresence, but you know, in a restricted fashion, meaning that the physician's usually in the same room. So they may not be right at the patient bedside, but they're in the same room. So eventually the Da Vinci robot, the company Intuitive Surgical was spun off with venture capital funds, and then the Da Vinci robot received FDA clearance in the year 2000 for laparoscopic surgery. And so this is what the Da Vinci robot looks like, and you can see that the physician's actually at the console here and not at the patient bedside. So this is really kind of the concept of telepresence. And this really brings up kind of what the goals of robotics are, differing between general surgery and then stereotactic neurosurgery. So for laparoscopic surgery really is the gold standard for minimally invasive general surgery, but this is somewhat challenging to perform because of the limited degrees of movement and the transmission of tremor through the imaging. But devices like Da Vinci help overcome these shortcomings of laparoscopic surgery by allowing telepresence and actually allowing the robot to control the camera. So that takes away some transmission of tremor and then the limitations of movement. That's not really the goals from our standpoint, from a neurosurgical standpoint. We're looking more at robotic assistance, which is allowing for accurate or precise placement of whether there be depth electrodes or a biopsy, and then the speed at which we do this. So telepresence is really not something that is currently done in neurosurgery. So one can think of general surgery as being more robotic surgery, whereas this is robotic assistance, and that's where the name ROSA comes from, Robotics Stereotactic Assistant. So speed and safety is what ROSA can do for you, and here you see a Shelby Super Snake, a fast car, but also good safety ratings. It's just a little plug for Ford. So Dr. Gonzalex-Martinez came out with this nice article comparing frame-based stereo EEG to ROSA-guided stereo electroencephalography. And as you can see that all the patients had about 13 electrodes each. The accuracy was pretty similar. So both really precise, but the time of implantation differs by about 2.5 hours, a significant difference there. So sort of stereo EEG is really the quintessential use of the ROSA stereotactic robot, allowing for not only safety, but particularly speed, which also equates to safety, as you'll see. Just obviously being under anesthesia for 2.5 hours less time is very important. Less than 1% hemorrhage rate per electrode.
I love technology, but it is infinitely better with people. Sometimes you just need that real human touch, that empathy.
All right, moving along here. Okay, so stereotaxy. What is stereotaxy? It's a minimally invasive option for localizing targets in the body. So we're going to move into, so there we go. Three-dimensional coordinate system to localize small targets in the body. So it comes from the Greek word stereo, which means three-dimensional, taxis, which is orientation. And I've thrown up 3 navigation instruments for ships. One is the Sunstone in the 13th century, the Sextant in the 1800s, and then now we have GPS. So a simple way to explain this to patients is for stereotaxy is basically saying that this is it's basically a GPS for your brain. Allowing us to localize a target in space in your brain without seeing that target. And this is a kind of stereotactic progression that one would go through in practice, and that I've gone through, first using the Lexel stereotactic frame for stereo EEG, moving into frameless manual procedures such as stealth neuronavigation, and then eventually moving into ROSA robotics. So these are several of the options, and of course there's many frame options available, and there's other image guidance systems besides stealth. So then now we're going to move into talking a little bit about ROSA. I'm going to who, what, when, where, why of ROSA. So what is ROSA? It's a fully integrated stereotactic system. It has proprietary navigation software, frameless registration, and then an automated navigation arm. So, but again, this concept of the surgeons controlling the instruments, it's robotic assistance, it's not robotic surgery, we're not using telepresence. So here are some cases when to use the ROSA. So as I already mentioned, stereo EEG, this is a big time saver. Brain biopsy, consider brain biopsy in a deep location. Laser interstitial tissue thermoablation, trigeminal rhizotomy, which is a little bit of an overkill, but it can be done. Ventricular endoscopy, deep brain stimulation, and then placing leads, depth leads for responsive neurostimulation. So from a standpoint of preoperative planning, how to do this. So first is obviously find your appropriate case, some of which I just mentioned. And then a rotoprosical CT and an MRI. Both of these are thin cut 1 millimeter slice volumetric scans. The MRI I use is double dose gadolinium. You really want to see your arteries and veins really well so you can plan everything in an avascular trajectory. And then you can merge these scans, the CT and the MRI, on the laptop and plan at your convenience leisurely, or you can plan on the robot. But the idea is to try and plan outside of the operating room to save the time and to be prepared for the day of surgery ahead of time. So you have a couple of registration options available to you. The first and the most commonly used is laser scanning of the facial features, much as we do with Stealth and other image guidance systems. There's direct skull fiducial placement. I would use this. I would do this in a case where the patient's prone, where you obviously can't register their facial features, and then small deep targets of concern. So the workflow for this is in the preoperative area. You'd place your skull fiducials, you get a CT scan, and then the patient goes to the operating room. If you're fortunate enough to have an O-arm or an intraoperative CT, then you can just put the patient directly to sleep in the operating room, place your fiducials, do the scan, merge it to your MRI, which you would have already done your planning on, and then you can register at that point. And there's one more registration option, which I've not used up to this point. You can register directly from the Lexel frame. I don't have any experience with this. You have to send your frame into France, where the company headquarters is, and they have to do some testing on your frame. But it is an option. So head fixation options. So the Mayfield works well in most indications, except in bilateral stereo EEG. The reason for this is that the arc on the Mayfield usually gets in the way of placing electrodes and the robotic arm. So these are two options, or whatever other fixation options you have available at your institution. This is basically just using the frame portion of the Lexel frame and not using the arc and coordinate system. And then the nice thing about this is with the new system they have, this is the connection you'll see to the robot itself. And they have this extra pin in here, which actually goes all the way inside the Mayfield and tightens it up. So it takes away the toggle that you have in your Mayfield. So this is actually a really tight connection. So you lock the patient's Mayfield directly to the robot. So here's the difference between the workflow that you would use in a manual frame case versus a robot. So in your manual frame case, such as a Lexel, you would MRI as an outpatient. You could pre-plan your electrodes to some degree, and then the patient would come in. They'd get sedated. You'd place the head frame on, take them to the CT scanner, then go to the operating room, and then you'd have to merge your CT and MRI, and usually have to adjust your plan a little bit. And then for every single electrode with the Lexel frame, you have to change 7 coordinates. And this is all manual, obviously bringing in patient or bringing in human error. And then this obviously, this merging and adjusting plans takes some time. Versus robotics, everything's done prior to the patient coming home. They come into the operating room, you register, and then you move forward with surgery. So it saves time pre-surgically, but also during the operation itself. So here's an example of a stereo EEG case. This kind of brings up the point that I wanted to make about really having robotics really allows you to move forward and push the envelope when it comes to stereo EEG and the amount of complex cases that you take on. This is not really a scheme that I would consider implanting in somebody with a frame, because this would take all day. So the increasing complex patients that you might get as you start to do more complex stereo EEG cases, the MRI negative epilepsy, patients with multiple foci, prior operations, bilateral cases, deep mesial cases. Here's an example of a lit case. You can see the treatment area. This is a hypothalamic hamartoma. You can see it's a very small hypothalamic hamartoma. Here's the post-treatment scan, but this patient had gelastic seizures. I'm not going to talk any more about lit. That's what Jorge is going to be talking about. But I just wanted to show you what you can do with robotics. That particular patient had fiducial placement just because it was such a small target and very deep. Brain biopsy and a deep critical location. This is also somebody that had fiducials. As you can see, a lesion there in the midbrain. It's not really a time saver, obviously, for a brain biopsy because it's one target. And then with RNS, here this patient is prone. This is a typical bitemporal RNS case for me, where there's a burr hole bilaterally in the occipital region. And then you have 2 electrodes going in, both long distance, sparing the hippocampus and the parahippocampal gyrus on each side. So you can see the stylet through the robotic arm. And that's what the leads look like on X-ray. Here's a case we did with percutaneous trigeminal rhizotomy. Again, it's overkill. I just wanted to show that lots of things can be done with the robot. This obviously can be done with X-ray or image guidance. So finally, I wanted to talk a little bit about what ROSA can do for you and your practice. Obviously, the biggest and the most important thing to me in all my cases is time efficiency, especially with stereo EEG. This is important for several reasons, obviously. It improves safety for patients because they're in the operating room for less time. It allows you to do more stereo EEG cases and avoid grids, which carry more morbidity. Allows you to do avascular targeting. From the standpoint of what it can do for your hospital and billing, obviously your less OR time is less OR dollars. This also equates to more time in the operating room for other additional cases, whether it be you, one of your partners, or another surgeon at your hospital. And then doing the CT scan on a day prior to the operating room unbundles that, and it's not bundled into your, so it's separately billable. It's not bundled into your hospital stay. And then from a marketing and recruiting standpoint, this allows for self-referrals. Patients find out that your institution has robotics. That's sort of a catch-all. And then physician referrals. And then finally, from a standpoint of capturing the best and brightest epileptologists, a lot of those folks are going to be training in institutions where they have robotic stereo EEG programs. And that's all that I had. And I know we're going to save our questions for the end.
Great. Thanks, Mike. That was great. So we're going to move on to our next talk on laser ablation. Okay, our next speaker is Jorge Gonzalex-Martinez from Cleveland Clinic.
All right, good evening, everybody. It's a pleasure to be here. Let's talk for 15 minutes about laser ablation and what is exactly laser ablation. So laser ablation for epilepsy, it's a minimally invasive neurosurgical procedure I just want to alert you about the term minimally invasive. I think it's sometimes it's disturbed to say that an operation that, you know, really we are putting a probe and then under general anesthesia is really minimally invasive. I think we can call this as less invasive epilepsy surgery, but I think we need to be careful by naming this minimally invasive. It may give us the wrong impression. But anyway, this technology creates a 2 centimeter diameter ellipsoid terminal lesion in the brain, which is in some cases for medically intractable epilepsy, that's the amount of destruction of the tissue that you want to obtain in order to control the seizure. It combines real-time MRI thermography with feedback control cooled laser technology to maximize safety. So it's a truly minimally invasive procedure, less invasive procedure, and has FDA cleared device for tissue coagulation in neurosurgery. And see clearance is still pending at this point. So when we talk about how less invasive this is, we're talking about a single, in general, 4 millimeter incision with a 3.2 millimeter hole and 1.6 to 5 millimeters trajectory. So here's an example, as you can see here on the right side, the implantation bolt with in a small pediatric case, in a small patient, and then the insertion of this laser ablation probe. So the really incision is small. We do have a confirmation of targeted before ablation, which is it's great for safety. And we have also this automatic manual shut off. So you have completely control and a live visualization of the lesion during the time that you perform the lesion. So it's really that is very, very control for the surgeon. And it has immediate effect with minimal hospital stay. And this is important in comparison, for example, with Gamma Knife. So as you know, Gamma Knife, it has some delay in treatment. It requires sometimes more than 6 weeks or 8 weeks to start we see some biological effects on the radiation. And with laser ablations, we are talking about immediate effect. So this is an advantage. So laser or thermocoagulations is not new for neurosurgeons. It's been done in functional neurosurgery for many, many years. So what I wanted to highlight here, this is a different technology. Here on the left side, you have a picture of RF-generated thermocoagulation in an animal tissue, showing that there is this area of ablation. But what I want to here highlight is the transitional zone between the health tissue versus the ablative tissue. So you can see here almost 1 centimeter in this transitional zone. It's a pretty large area. In comparison here on this side, on the right side, you have this laser ablation thermocoagulation tissue, showing that this transitional zone is really much less. We're talking about 1 or 2 millimeters maximum, which again talks about how safe this technology is, not only in the visualization, but the control, but also how precise we can perform ablations now in critical areas in the brain, areas that are very close from eloquent cortex. So let's see to the next slide. Very good. So what are the applications of laser ablations? There are several applications. Laser ablations can be performed mostly in patients with mesotemporal sclerosis, patients with focal cortical dysplasia, and for example, hypothalamic hamartomas. So I think hypothalamic hamartomas, in my opinion, is one of the greatest indications for laser ablations. So this is a difficult pathology to treat. And I just want to give you a historical perspective and some review in the literature here. So the classical approach for hypothalamic hamartoma is what we call anterior interhemispheric transcallosal. It's a complex procedure that brings us a seizure-free outcome of approximately 50%. So not bad for this type of pathology. However, take a look here, the morbidity associated with a hypothalamic hamartoma through an anterior interhemispheric transcallosal approach. we're talking about almost 50% of those patients will develop some sort of memory dysfunction, with approximately permanent memory dysfunction in 30% of those patients. We're talking about an additional hypernatremia, 55%, obesity, 45%, so all endocrinological side effects. So it's a quite morbid procedure. When we go to the endoscopic approach, it's a different advantage that we obtain with seizure-free outcome, maybe a little bit less, 46%, but it's still in the same ballpark. But when we talk about it, the complications, much less compared to the open. We're talking about memory dysfunction in 8%, but also risks for stroke in 30%. It's still a quite morbid procedure. So let's see here what we have in relation when we see a patient treated with laser ablation. This is an example of a hypothalamic hamartoma, approximately 1 centimeter in diameter, center in the hypothalamus. This is the MRI Sather showing this lesion. Other views from coronal and axial flare showing how this mass is located in the right hypothalamus, a clear picture, typical picture of hypothalamic hamartoma in a patient with gelastic seizures. So when we use laser technology, what we need to perform here is patient goes under general anesthesia. We attach the patient's head some sort of localization system. In this case, this is the CRW frame. That is the planning of this trajectory through a transfrontal approach, the insertion of this small laser catheter through this transfrontal approach. Once the catheter is in place, let's see here, the next slide. Very good. Those are intraoperative images of the catheter. Now we have the confirmation of the laser catheter that is well placed in the hypothalamic hamartoma. You have the live tomography showing the formation of this lesion in a lifetime. And here is the post-ablation imaging showing the ablation, the partial ablation of this hypothalamic hamartoma. So it's a really safe procedure and well-controlled procedure as you can see here. Next slide here. And results are still under view. Sorry, I just want to go back here. Anyway, I cannot go back, but what we see here on the results is that, there we go. So according to this manuscript here, we have 80% seizure freedom for those patients, but what I want to show to you, I want to highlight is how less morbid. We're talking about a rate of complications that is probably less than 10%, probably around 5%. So really, this is a technology that provides much less morbidity to patients with hypothalamic hamartoma compared to other methods. It still is difficult to compare the results in terms of seizure freedom because we have much less patients treated with laser, and it's difficult to compare with the more standard. So this is something that we still need to prove to ourselves, that the laser ablations with hypothalamic hamartomas are efficient compared to the open procedures. Let me see here, the next slide. Very good. Other examples are periventricular nodules. This is an example of periventricular nodules that are located in the right atrium. This is the image, the live image is showing the formation of the ablation. You can see here the different colors showing the different lines in temperature control during the procedure under intra-op MRI control. And next. And very good. This is the final aspect of ablation of a periventricular nodule here with the post-op T2 showing the enhancement or the T2 changes in this location. So with a complete ablation of those periventricular nodules. So I just want to also highlight that not all periventricular nodules are epileptogenic. So it's important to first understand which ones are epileptogenic or not. And then if the volume of ablation is small and within the capability of the laser ablation, this is a good procedure. And again, this would be a difficult procedure to do open, definitely feasible, but you need to go through this health tissue here. On the dominant side, not so complicated, but imagine if you have the periventricular nodules on the dominant left side, you need to go through the dominant parietal lobe, will make the open procedure highly morbid. So laser ablations for periventricular nodules are, it's a good option for those patients, and it's a very good indication for.
It's 9 o'clock.
So other indications are lesional epilepsy, and the main indications here in our country is mesotemporal epilepsy in mesotemporal sclerosis. I will show you a couple pictures of how we perform this. Normally, this is an intra-op MRI picture showing the insertion or the orientation of the laser catheter going through a temporal occipital approach, all the way targeting the mesostructures, mostly the amygdala, the head of hippocampus, and also the tail of hippocampus. So you can eventually have the ablation with one single trajectory. Those are images, the live tomography. The first ablation is normally performed distally in the region of the amygdala and the head of hippocampus. And after performing this ablation, we normally retract in couple centimeters the laser catheter, as you can see here, and you can perform a second ablation that will take care also of the body of the hippocampus. So it's a quite straightforward procedure. It's a procedure that takes, in general, 2 or 3 hours. This, or a little more because of safety features in the intra-op MRI, for example. But this is an example how, what's the magnitude of the ablation. Here is the first, the pre-procedure ablation with a catheter confirmation in the mesostructures. This is the visualization in the intra-op tomography with the estimation of the damage. And here is finally the confirmation of the damage with a post-ablation contrast MRI showing almost a good ablation of the mesostructures. Not complete ablation, as you can see here. There are portions of the amygdala, the hippocampus, and parahippocampus are still not ablated, but definitely most of the mesostructures can be ablated with this approach. This is a series of post-op MRIs showing the magnitude of this ablation. Here is the location of the mesostructures on the right side, so we can compare. So you can see here a pretty decent ablation of the hippocampus, a partial ablation of the parahippocampus. This is another more rostral cut on the MRI, again with a very good ablation of the hippocampal formation in this section. But also, I just want to say that with the preservation are not possible to ablate in this case the parahippocampus. And an additional cut, a little more rostral, with some very partial ablation of the uncus and the amygdala. So I think those slides can show to us that although we can perform the ablation in those regions and we can perform a large ablation in the mesostructures, we need to be clear that the ablation is incomplete in the mesostructures. So this can account for the maybe less efficiency of the procedure when we compare it with the standard temporal lobectomy, where we really remove the entire mesostructures, the amygdala, the hippocampus, and also the parahippocampus. And as we know, the amount of ablations that we perform or the success rate of epilepsy surgery in mesotemporal sclerosis is related to the amount of resections that we perform in the mesial temporal areas. So it's normal to understand that the efficiency of this procedure would be less than the standard temporal lobectomies, and the patient should be aware of that. So those are the results. Again, it's difficult to compare with the standard. This is 1-year outcome, 50% angle 1, seizure freedom, or with auras, 23% angle 2. So definitely less efficient than the standard, but it's still in a very, very interesting results compared to other techniques. What it calls our attention is the amount of morbidity, and mainly the morbidity related to neuropsychological outcomes. So if you're performing this on the dominant side with partial preservation of memory or with full preservation of memory, you're going to have a remarkable decline in the memory using standard temporolectomies. And this decline is less evident or less impressive with laser ablations. And this is because probably you're ablating less tissue with laser compared to the standard temporolectomies. That's the reason why. So it's a trade-off. We're trading efficiency versus a low morbid procedure. So indications need to be careful, and we need to find the right group to perform the laser ablations for mesotemporal sclerosis. So just go back to the outline of the procedures. I think we still have a couple more minutes. First is the planning. Normally we do this with a high resolution volumetric MRI. After is the placement of the laser catheter, and finally is the thermal ablation. So the placement can be done with any sort of stereotactic apparatus that you have available in your institution. For example, like a frame or more sophisticated robotic devices, as Mike showed you before. We also, we do laser ablations using our robotic devices here. I think it provides us a very good precision in a system that is a frameless system. So for us, it's something that is very, very comfortable using this robotic device. So robotic devices can be performed, or laser ablations can be performed in the MRI suite. So after, or the placement of the the laser catheter can be performed entirely in an MRI suite or outside in a regular MRI. Currently, we have two systems available. One system from Medtronic, Visual Aid, the other from Neuroblade, Monteris. They are very similar. I use both systems. I don't see any major difference. There are some details. So, for example, Visual Aid system is the same cool system compared to the CO2. It's a small catheter, 1.65 millimeters cannula. And what I think it's interesting point here is that the amount of ablations that we can have, approximately 80 millimeters in diameter. Monteris, on the other hand, it's a CO2 cool system that has a more, it's a larger cannula, 3.2 millimeters. So I think this is some limitations when you're talking about putting cannulas in very critical areas. For example, the hypothalamus is small pediatric patients. I think this is something we need to take into considerations. But for me, one of the advantages that we have with the diameter of the catheter is also you obtain a larger diameter lesion compared with a small cannula. So I think they're very similar. I think you need to make a very clear decision, and depending on what's the pathology, where we're going to make a lesion, and what's the age of your patient in order to decide what type of system you use. So again, we have a follow-up images that I showed before, so we can really confirm the ablation. So I just want to, this is a video, I think I will skip this one. So this is an example. What are the limitations of the laser ablations? Is definitely there is a strong heat sunken phenomena where you cannot heat efficiently in areas very close from the CSF spaces. So because of the shunt effect. So this will give us some incomplete ablations in areas that are very close from the ventricular system, from the CSF. And this is a limitation that we need to be aware every time we do a case. Here in my hospital, we have a large series of patients with non-lesional laser ablations guided by SEG. This is an example with very good localization, but with a normal MRI. This is an example of an SEG implantation, and we saw a very focal onset, and we can perform as we did a small lesion, a small ablation over here, and this patient has been seizure-free for more than 3 years. So we have a series of those patients. Those are very, very selected patients. I think we need to be careful. There are patients that have a very, very focal onset on SEG, and not all patients are good indications for this procedure, but we do have in some patients good results with this approach. So to finish here, I think I want to really emphasize what are the challenges. The main challenge in my view is the volume of treatment is really small, so you need to have very clear indications. Patients with the small epileptogenic zones are better candidates for this. Thermodynamics is an issue, as I showed to you. Electrophysiological feedback lacking is another problem, and the lack also of functional MRI is it's another limitation. But I think what the laser ablation really brings to our field is a different mindset in epilepsy surgery. So in the past, we have the concept or the idea that there is only one good surgeon to be performing our patients. So in ablation procedure, this changes because you can perform, we have the opportunity to ablate several segmented approaches. So you can perform an ablation, explore best targets and trajectories and observe, and then probably re-explore or re-ablate if needed. So it really brings a new perspective to epilepsy surgery. And I think those are my last slides. I just want to thank you for your attention. Thank you so much.
Great, thanks, Jorge. A great presentation. We're now going to transition to our third talk. Okay, so I'm an assistant professor of neurosurgery at UCLA, and I'm going to be talking about deep brain stimulation of the anterior nucleus of the thalamus for epilepsy. So just to give a quick overview, these are the FDA approved indications for deep brain stimulations in the United States currently. I've highlighted the 3 movement disorders in blue: Parkinson's disease, essential tremor, and dystonia. There's 1 psychiatric disorder, obsessive compulsive disorder, and more recently in the fall of 2018, epilepsy became an approved indication by the FDA. Specifically, DBS of the anterior nucleus was approved in 2018 as adjunctive therapy for medically refractory epilepsy. It's specifically indicated for partial onset seizures in patients greater than 18 years of age with seizures with or without secondary generalization that are resistant to at least 3 or more anti-epileptic drugs. So just to review, the underlying theory behind deep brain stimulation is the modulation of specific circuits. So for example, deep brain stimulation for movement disorders is based on targeting nuclei that are involved in the motor circuit. Deep brain stimulation for disorders such as OCD and other experimental indications such as depression is based on modulating mood or affective circuits. And DBS for epilepsy is based on modulation of the epilepsy network or epilepsy circuits. And so we all know about the circuit of Papez or Papez, depending on where you fall on the pronunciation. And this is just an overview of that circuit that's known to be important in the propagation of seizures. So we can start with the hippocampus, and we know that the hippocampus sends out efferents via the fornix to the mammillary bodies here, and the mammillary bodies then project to the thalamus via the mammillothalamic tract. The nucleus that receives that input is the anterior nucleus of the thalamus. This then projects efferents to various areas, including the cingulate gyrus, which we know then sends efferents back to the hippocampus. And we can see here on an MRI, on a sagittal section of the MRI, which nicely outlines the anterior nucleus of the thalamus here. And you can see a few white matter fibers. One here that's just coming into view is actually the fornix. More posteriorly, you see this large bundle. This is the mammillothalamic tract. And there are some fibers that are outlining the nucleus itself. So you can see here the outline of the anterior nucleus. So as shown here, this is a rat pilocarpine seizure model. And we see control injections here. And what we're looking at here is the duration of time in a seizure-free state. And you can see that bilateral deep brain stimulation of the anterior nucleus increases the seizure freedom time, as shown here. Interestingly, unilateral DBS was not as effective as bilateral DBS, And this is something that's unique in terms of people who may be familiar with deep brain stimulation for other disorders. For example, essential tremor and Parkinson's disease, where stimulation of the targets for those disorders controls symptoms on the contralateral side. Whereas in the case of deep brain stimulation for epilepsy, it's important to realize and understand that you really need to have good bilateral placement to achieve good efficacy. This is just an overview of the various neurostimulation options available today. VNS is obviously an established therapy, adjunctive therapy for seizure control. And I'm not going to get into all of the details here. You can review this on your own. But I just wanted to kind of compare the three here in terms of the fact that they have different, slightly different indications as well as different side effect profiles. DBS is the newest comer to this, and RNS is also is responsive neurostimulation, which is also used for non-receptive candidates. And it's based on a closed loop model of neurostimulation. So a lot of the data that we have on deep brain stimulation of the anterior nucleus is based on the Santé trial. This was a trial that involved 110 patients from multiple centers in the United States and was a double-blind placebo-controlled trial. This is just to show you what were their stimulation. This included an amplitude of 5 volts, pulse width of 90 microseconds, a frequency of 145 hertz. And the electrode configuration was typically unipolar mode with either a single or adjacent contacts negative, with the case being positive. And all the patients in Santé were in a unipolar mode. It's also important to realize that the therapy for this form of deep brain stimulation was similar to vagal nerve stimulation in that it was a cycling mode with 1 minute on and 5 minutes off. Other features of Santé were the fact that they specifically used the Medtronic 3387 lead, which actually is currently not the recommended lead by Medtronic for this procedure. And I'll get into that in a little bit later. So this is some of the data from the Santé trial. This is actually showing the blinded phase, showing looking at median seizure frequency, the percent change from baseline. And you can see relative to the control group, there was a 40% reduction in seizure frequency compared to the control group, which was 14.5%. But if you look, interestingly, at the longer term results of Santé, you can see that over the years, there's an increase in the percentage of subjects who responded to therapy and an increase in the seizure control rate over time, up to 60 to 70% over 5 to 7 years. So the actual components of the system are very similar or identical to deep brain stimulation for movement disorders, in that you have an electrode placed into the brain, you have a pulse generator, which lies inferior to the clavicle in a subcutaneous pocket, and an extension wire that connects the intracranial electrode to the pulse generator. And again, unlike some movement disorders, this is a bilateral therapy in all cases. This is the nominal target based on the Schaltenbrand Atlas, which is 12 millimeters superior, 5 to 6 lateral, and 0 to 2 millimeters anterior to the mid-committee. Schaltenbrand Atlas at a 5.5 millimeter lateral plate, showing the nominal target. So it's another unique feature of DBS of the anterior nucleus is that there was a high percentage of revisions in the Santé trial, I believe up to 8%. And it was found that the anterior nucleus, unlike some other subcortical structures, had a high variability in its location between subjects. So we do not recommend just using the nominal Schaltenbrand-based targeting. And for this reason, it's important to get a preoperative MRI using the proper sequences as shown here. So these are two sequences that can be used. We have an MP RAGE here on the top showing the hyperintensity that I showed before, which outlines the mammillothalamic tract and the anterior nucleus that's shown here. You can also get special stir sequences like the F gator sequence that is shown here in the bottom panel, in which you can see very nicely the mammillothalamic tract, again with the target outlined here. This is an actual case that we performed recently, showing our own targeting of this structure. Again, this was an MP RAGE image, a sagittal MP RAGE, showing the fornix here anteriorly, and you can make out the mammillothalamic tract coming here, and then you see that there's a kind of a splaying of these fibers and an outlining of the anterior nucleus here. Again, this is the MyAtlas showing what the location of the nucleus is on a coronal section. And again, from our own case, showing a coronal section here. Again, you can make out the mammillothalamic tract on both sides here. You can see it here. And on this side, you can see it here. And you can make out, here's the outline of the contralateral anterior nucleus. And this was the ipsilateral nucleus. And we were targeting both, but this is just showing you the targeting on this one side. So what we're doing at our center is to target the point at which the mammillothalamic tract actually bifurcates just under the nucleus on the coronal section, as shown here. One method of finding the appropriate location for the targeting is to divide, outline the thalamus as an ellipse here and to divide it into quadrants. And you really want to be in the anterior superior quadrant as shown here. This is a good rule of thumb. If you find that you're in this posterior quadrant, you're probably too far posterior. So again, this is showing the same concept with the quadrant method, showing the location of a 3387 electrode in the nucleus. Again, for our current cases, we actually utilize a 3389, and you can see why. The 3387 was used in the trial as they were required by the trial guidelines to use that electrode because it was a clinical trial. But you can see that it really, if you use a 3387, you may only get one or two contacts at most within the nucleus itself because of its small cranial or dorsal ventral distance. So using the 3389, you increase the probability of getting an active contact within the substance of the nucleus. So in terms of frame placement, you can use either a traditional Lexel or CRW frame or a mini frame that's shown here. At our center, we utilize both systems, but more frequently for the anterior nucleus, I'm using the Lexel frame. This is just showing you a 3D reconstruction of the mammillothalamic tract. Again, with the anterior nucleus shown here in red. And this is to highlight that unlike targeting for many other disorders, you really have to use a transventricular route. In fact, the FDA approval is for a transventricular targeting, not for extraventricular, although there are some centers, particularly in Europe, that have utilized the extraventricular approach with mixed results. We are recommending a transventricular route, as this will get you directly into the anterior nucleus with your active contacts spanning a good proportion of the nucleus. So unlike other movement disorders, there are some unique challenges to targeting the structure. It is a midline structure. There are some unique challenges to this. One is there have been case reports with this approach in which some centers have had some cases in which the electrode skived off into the interventricular foramen of Monroe. Other unique features are the vasculature in this area. So you have the internal cerebral vein here, and you can see the thalamostriate vein and the superior choroidal vein, and your target is really wedged in this tiny window in between. And you can see here, you can see these veins and how you have to really thread a needle sometimes to get a proper trajectory into this location. This is another one of my cases showing that this can be a particular challenge. As you can see that this was a very narrow window between these two venous systems to get this into the nucleus. And often what this will require is a non-traditional approach in terms of the fact that often we're using a pre-coronal entry point when we target movement disorders. And as you can see here, I was just on the coronal suture in this case, and I even contemplated coming a centimeter behind the coronal suture. So for this reason, there are some unique challenges and considerations when targeting this structure. And for these reasons, I really highly recommend performing some form of pre-planning before the actual day of the OR, so you really know what you're getting into and what challenges you might be facing in the OR on that day. As many of us may be used to just coming in on the day of the OR and doing our planning in the back room, I probably wouldn't recommend doing that, at least for the first several cases that you do for this nucleus. At our center, we have the luxury of the Aero CT, intraoperative CT system. And so I have been using this. I typically do not use this for my movement disorder cases, but I found it useful, especially in my first few cases, to do this when I was targeting the anterior nucleus. Given the experience of some other centers, like I mentioned, some people had cases where the leads had skived into the foramen Monroe. It is a midline structure. There is some critical vascular structures nearby. So what I'm doing is before closing, I do an Aero CT spin, and this allows me to verify that I'm in a good location, and also it serves as my post-operative CT, and that the patient does not have to get a post-operative CT after leaving the OR. In addition, we do microelectrode recordings. The patients are asleep. We do use inhalational agents, which are titrated at the time of the actual recording. This is to provide another additional information in terms of the span of the nucleus, and you can see that when you're in the nucleus, you actually get bursting activity in the thalamus. And as you go in and out, you do pass some white matter structures, and you will see quiet areas as you traverse those white matter tracts, as I showed before. This is another 3D reconstruction. This time, this is showing the concept of using an at-target cannula. So again, there's a transventricular route that's recommended, and at some centers, we're used to using cannulas that are stopping 15 millimeters short of the actual target. And in those cases, your cannula stops in the body of the lateral ventricle, and there is some distance in which your lead would have to traverse a ventricular system before penetrating the parenchyma. After speaking with many other centers, we don't really recommend this, as this might be contributing to some of the lead skiving. And so we have actually started using a long 192 millimeter cannula in conjunction with the NeuroOmega microdrive system, so that our cannula goes all the way to target or a little bit above target, so we can do some microelectrode recordings. But the key point is that the cannula does traverse the actual nucleus. So just to summarize some of these key points, we do our cases often with the patient asleep, particularly in epilepsy surgery. These patients often have unique characteristics which make them difficult candidates for awake surgery. So I do these cases asleep. I highly recommend planning the cases in advance. Intraoperative CT, if you have it available, can help. Otherwise, you can use fluoroscopy for guidance. We use the 3389 electrode with the long cannula, and then we perform intraoperative impedance measurements as a secondary check to verify that we have all of our cannulas within or past the ventricle. So that's another point that I want to emphasize, is that given the 4 contacts, we do plan such that the first 2 contacts are definitively within. Therefore, the bottom 2 contacts will most likely be ventral to the actual anterior nucleus. Postoperative programming is performed in 2 to 3 weeks. People have described in the literature up to a 20% reduction in seizures from an insertional effect. These are some of the reimbursement codes which are interesting to look at. This is for a staged implant. You can see the reimbursement is significantly higher than if you're doing a non-staged implant. This is for the facility fees. And then this is the physician reimbursement numbers right here for your reference. So with that, I'll conclude. And at this point, we can take questions from the audience for any of our speakers. Thank you. Okay, it looks like we don't have any burning questions at this time. Again, these videos have been recorded and they'll be uploaded for your benefit for future reference. And if you have any questions, feel free to contact me or any of the other speakers via email if you have any questions. Thank you. Thanks, Jorge, and thanks, Mike, for giving your talks. Both were great talks, and look forward to working with you in the future.
Yeah, I appreciate it. Thanks for hosting.
Thank you so much. Goodbye, guys.
Bye now.
Bye.